Hi, I would like to welcome everybody. I'm Kathy Rowe, the Executive Director for New Jersey Advocates for Aging Well, and I'd like to welcome you today for the fifth webinar in a series we're doing with Parker Health. Today, we're going to talk about infection control, and we have with us today Carolyn, the Chief Clinical Officer at Parker Health, Judy Collett-Miller, the Director of Technology Innovation, and Bharathi Honnurappa, the Corporate Infection Preventionist at Parker Health. I welcome the three of you here today. And Judy, if you want to start us off with a video about Parker Health.
Sure.
What does it mean to grow old in America? What if there was a new way of thinking about aging? And growing older meant staying involved and being connected to people, communities, and the world at large. There are more than 50 million people in this country who are seniors, and that number is expected to nearly double in the next 30 years. We know that aging can be complicated, but it's time we acknowledge, celebrate, and plan for it in all its dimensions. Together, we can embrace a mindset where people of all ages find fulfillment, and we go from thinking about what we can't do as we grow older to our deciding what we want to do more of. There's a place that's getting the story about aging right. From residents and families, to the employees, to children racing through the halls. Since 1907, Parker has been challenging, changing, and expanding the idea of what it means to grow older in America. What does it mean to grow old in America? What if there was a new way?
Stopped a little quick there.
Thank you. I think that's a great representation of not just what Parker is doing, but aging in New Jersey today. So as we go through, if you have questions for our panelists, you can put them either in the chat or the Q&A. We will address all questions and I will be monitoring them. Let me share my screen so we can start. Can you see that?
We can, thanks, Kathy.
Okay, I'm going to mute myself and turn myself dark and take it away.
So I'm just going to spend 1 minute here. So my name is Judy Collett-Miller. I'm the Director of Technology Innovation at Parker. It's Carolyn, Bachonski, and Bharathi. So we've got Carolyn and Bharathi with us. We know we have a varied audience today. I think I saw some long-term care providers, some affordable housing, I looked some governmental agencies. So while the content is going to be primarily long-term care and senior living specific, we do think there's some takeaways and learnings for everybody. And as Kathy said, as you put your questions in the chat box, we're going to try to address them as we go along so we can make sure that we're answering any questions that you may have. So please feel free to put those questions in the chat throughout the program, and then we'll also have time at the end. I'm just going to give a quick update. We're going to talk initially about our approach to infection control and how COVID changed that work very quickly and how it changed our infection control work going forward. We're also going to talk a little bit about how we use technology to support infection control. So we were having a little chat beforehand, and some of this might be a little more high tech, some of it's more low tech, but it's some initiatives we have in place, and we want to talk about how they are helping us with our infection control efforts. We're also going to talk a little bit about how we use or trying to use data for decision making, right? So you've got data from lots of sources. How do we collect it? What are we doing with it? And how do we use it to make better decisions around infection control? And what I want to say is data is a journey for everyone. We're in one ourselves. So what we used to do, what we're doing now, and what we're working towards are very different things. And we'll tell you a little bit about that. And then we're going to just give some early learnings. Kind of what we've seen, what's changed, what we think is going to continue to change. And I think that might be a really good opportunity for some discussion amongst the group if we have time about that. So while we're going to talk a little bit about COVID, the whole program isn't going to be specific to COVID infection control. We want to make sure everybody understands that. Can you do the first slide, please, Kathy? So I just want to talk a little bit about Parker very quickly. So like a lot of you on this webinar, we have a variety of settings, and these settings certainly influence, and particularly with COVID, influence some of the decision-making and implementation around infection control. So you'll see up in the upper left-hand corner is our original, what we call our legacy building. That's Parker at Landing Lane. That was the first Parker. A very, I think, more traditional long-term care building. Right below it is Parker at River Road. Again, a little bit more of a traditional model, but we do have a small memory neighborhood within that model. Up in the right-hand corner is Parker at Stonegate, which is our assisted living. So very different model. You guys are familiar with assisted living, but what I'll say related to infection control is this is a group of well elders and residents who were very used to having autonomy, being able to go out, driving. So when we put some of our protocols in place, it probably in fact impacted this group of residents a lot differently than it did some of our other residents who maybe don't have that same mobility. Right below that in the middle, this is Parker at Somerset, which we are undergoing a very, very large renovation and construction process, and there may be some comments around how this infection control work has happened in a very rapidly changing physical plant over there at Somerset. And then right below that on the bottom right is Parker at Monroe. So this home has multiple small home neighborhoods throughout, very non-traditional setting, big space, larger rooms, private rooms. So I just give you that background. So when Bharathi and Carolyn are talking, you'll realize, like a lot of you, is, you know, while decisions may be made across the organization that we implement, the way we implement them may be different because of the setting or the physical infrastructure within our homes. Along with our residential homes, we also have inpatient and outpatient rehab. We have an on-site child development center, and we also have 2 adult daycare centers, one at our building in Piscataway and one down in Monroe. So we are in Middlesex, Somerset, and Monroe are 5 locations. And with that, Kathy, if you can go to the next slide, I'm going to turn it over to Carolyn and Bharathi, and I think Carolyn's going to start us off, and then I think her and Bharathi are going to tag team on these slides and you know, just reflect on some of the things we have noted here. So it's all yours, Carolyn.
Great, thank you, Judy. It's a pleasure to be here with you all this afternoon and just share with you a little bit about our experience. I think it's fair to say that all of us have been through, I don't know, looking back, it's almost hard to imagine how difficult it was now that we've seemed to have at least emerged, at least from the most critical periods throughout this. You know, I think we see our world, at least I know I do, I define my infection control world as BC and AC, before COVID and after COVID. Because clearly, although, you know, COVID was the defining, you know, moment really in infection control processes and protocols, it really was an experience that gave us an awful lot of information about organizationally, how do we function, how do we operate, how do we communicate. So the bigger picture was really more about not only obviously how do we implement specific infection control processes and practices, but one, are we prepared? Were we prepared? If not, what did we need to do to prepare going forward? I've been a clinician a very long time, and infection control has always been a core competence in our work. But at COVID, I think what we all learned to realize very quickly is that infection control became quickly the core competence in all of our work. I think it's important as an organization for anyone out there to really realize that in order to be successful when crisis hit, when infection control, when a pandemic occurs, I don't think we've seen the last of what could ultimately become other types of major crisis in the infection control space as we go forward. We realize there's all kinds of things around the corner waiting for us, MDROs, multiple drug-resistant organisms. We know that antibiotic stewardship has become a very important part of the work that we do because there are superbugs out there all the time. So we know that this is really perhaps just an early learning for what may or may not ultimately come down the road. I think it's important though to recognize from an organizational perspective, in order to be really successful in managing these types of crises, there's really some key organizational competencies that are really important to think about. For us, we had a tremendous ability to be flexible. We could pivot early on. We were able to kind of instinctively see the writing on the wall, end of December, early January, know that obviously we were all kind of, on standby waiting for the next bit of information to come along. But while we were waiting for the guidances that emerged from, the regulatory sources, we understood clearly that something was coming, something was happening. And so we began to build quickly operationalize the infrastructure, building the infection preventionist role, starting the education among the teams and in our frontline people, getting back to those core competencies of infection control, hand hygiene, and those types of things. So early on, I think part of what helped us kind of manage things in a more contained way. We also, as a clinical team, had unfettered access to our leadership and the top leadership of the organization. And so that was lockstep day in and day out to be able to have those conversations about what do we need, what are we doing, where do we need to go. Decision-making was immediate. Decision-making was part of the day-to-day conversation. So our ability to implement and execute quickly early on was very important in trying to mitigate what was clearly coming down the road. I think it's also important for those healthcare organizations out there to really bear in mind that collaboration and partnerships became really, really critical. We were very lucky to have an infectious disease specialist as part of our team, as part of our organizational consulting system, even prior to COVID and even before it was a requirement. So the ability to have access to that level of expertise was really, really important in building protocols and processes and putting together things for the nurses to be able to just, with standing orders and certain things that nurses could operationalize very quickly, diagnostic tests that they could order because it was part of the medical protocol. Our medical directors and our physicians who worked with the organization, really, really great partners, having great relationships with these experts and these professionals, critically important in terms of being able to execute quickly. There was really no ego involved in terms of our medical directors. When the infectious disease doc said, hey, listen, I think this is the way we should roll with it, they were all in. They leaned in, they were all in, they supported it. So we were able to, again, get into the space quickly. If we detected the potential change of clinical condition on a resident early on, let's say January, February, we were already ordering some diagnostic workup that, as we all recall painfully, we had no COVID access to testing at that time, and we were a long way away from that. But through ID, we were able to understand that there were some markers, there were some other diagnostic work that we could do to be able to try to get answers as quickly as possible to what was happening with a resident. Bharathi, anything you want to add to those points?
No, that was certainly true. Like infection control consultants were really remarkable in giving support to us and making sure to see where the markers are. Can we isolate those residents and make sure that prevention protocols were in place?
So early intervention really is trusting your instinct as an organization, using your resources carefully, wisely, calling upon them as you need them, trusting that they'll be there and come through for you when you need them. And I think finally, one of the most important things that we really counted on throughout this process, at least I did as a clinical officer, and I think the clinical teams did as well, is that it really does take a tremendous amount of faith and trust in terms of the organization in the clinical leaders in their teams to execute what is necessary, building those relationships with physicians. So that clinical decision making, and again, we were very, very lucky to have early communication with our families and our residents, so that when the crisis really started to peak and we knew that trouble was clearly coming and in fact was arriving sooner than we had wished or hoped for, our families we had spent a tremendous amount of time communicating and providing information, and having developed relationships with those members along the way over the years. I think they really understood that we were doing the best we could. They trusted their loved ones to our care and control, and knew that we were doing everything in our power to make sure we mitigated the risk to all and kept everybody safe. So other challenges that we had early on, or things that we really were very mindful of, is that at the end of the day, engaging staff is really 100%, if not all of what infection control practices are really all about. We can write all the policies in the world, and certainly during this time, I can honestly say I probably wrote somewhere upwards of hundreds of policies, or maybe I just wrote 50 and revised them hundreds of times. It's hard to know anymore. But at the end of the day, all of the fancy, paperwork in the world for compliance in a binder is only as good as the people in the front line, those stakeholders at the bedside that are really empowered, that are educated, that are prepared to really do the work of infection control. And although we've had infection control in our world forever, we've talked about it forever, yes, they all know hand hygiene, 20 seconds, have to make sure we meet that requirement. What the teams really needed to understand was this was a much bigger conversation. Yes, hand hygiene was critical, but it was a lot bigger than that. It's interesting because I think part of our lexicon, all of a sudden in these early months, we developed a whole new language, right? All of a sudden, cohort was something we talked about all the time, and positivity rates and guidances. If I heard guidance once, I heard it 1,000 times as they were issued, many times from various regulatory sources. Positivity rate, Cali scores, IP, these are all, languages now that we've learned to kind of integrate into our day-to-day, donning and doffing. As I said, I've been a nurse a very long time, and I think if I used the words don and doff once a year, it was probably a lot. Following this experience became part of the day-to-day lexicon. We were talking about it constantly with everyone, right? Not only just our frontline team, but everyone who is responsible for following infection control practices. So Bharathi, you want to speak a little bit about, go ahead, Judy.
No, I want to ask before, I'm sorry, when you're deferring to Bharathi too, can you talk a little bit, Bharathi and or Carolyn, before we go on to the next slide, a little around the communication reporting, because we're talking about, making sure everybody's informed. And I know you two had both talked specifically about how we share with both our employees through our internal mechanisms and then our external mechanisms to keep them informed. So if somebody could spend a minute talking about that.
Sure. So we realized early on, as I think most organizations did, that there were multiple buckets, and we had to find a way to reduce silo operation, right? So that all stakeholders, all team members, all staff members had the same information consistent to their level of practice. So early on, we developed a task force before even the peak of COVID hit, where everything became locked down, and the decision makers for the organization were all involved in those conversations. They were held daily. So everyone was represented, the executive teams, the administrator for the homes, the directors of nursing, the infection control folks, the business, finance, sourcing, those who were, procurement, product. We all met daily to just continue to operationalize. What did we need? What did we need to do? What was right in front of us in the moment? How did we need to get that information out to the front? What did that all look like? And how did we ultimately accomplish the communication? Bharathi, you might want to add something to that.
So all the leadership team were at one table at doing a critical decision, ability to disseminate the information to all homes so that all DONs and administrators were getting the decision making at one time. We did meet very frequently in the beginning, and weekly, monthly. Right now we are doing at need basis.
I think one of the challenges too to added to the mix throughout all of this is that really what we were operating in what I call the alphabet soup of the regulatory environment. We had, inputs from CMS and CDC and DOH and EUAs and FDAs and all kinds of language whereby not everyone and not every organization or regulatory body was on the same page at the same time. So harnessing all that information, that global information, which was changing so frequently, clearly a challenge. So from an organizational perspective, it really needed to be owned not only by, let's say, the clinical person or the clinical team, but everyone in the leadership role took a part in making sure that we were sourcing the most up-to-date information, that it was being channeled to the people who were responsible for building policy and process around what was happening and the changes that were occurring sometimes 2 to 3 times a week. And that we were as well informed as possible to be able to make the right decisions for the organization. So putting somebody in charge of that process of gathering information in the midst of all of those different regulatory bodies, also very, very important lesson I think we learned. The information was a tsunami in many, at many points in time, and making sure that we got it right, that we stayed on top of it, that we were the most current was very important. But
Carolyn? Hi, Carolyn. We have a question that I don't know if you wanted to wait to answer it to later or weave it in because you were talking about staff. We have a question. Can you talk a little bit how the CNA and nursing shortage has impacted your organization in terms of COVID and infection control? What are you doing to recruit and retain your staff? It sounds like your staff was very involved with this process. So I just wanted to put that out if you want to answer it now or wait to the end. Or it might be something that you cover in your slides.
Sure. I think Parker as an organization has the blessing, if you will, of a very long-standing historical relationship with their employees. We have folks and team members that have been with the organization a very, very long time. So they were there, obviously, when we needed the most. I think the biggest concern and the critical nature came when early on, when people were positive or employees, were diagnosed with COVID and had to come out of the system for 2 weeks, 10 days, whatever it was. We were able to manage. We had the bandwidth to be able to meet all the needs of the residents. Not all organizations do. But clearly, subsequent to this, as the crisis has passed, I think the healthcare system in its generality has taken a tremendous hit. I think nurses are, and caregivers are tired. They're fatigued. They've worked under unbelievable circumstances. We, as an organization, were able to do some financial support in terms of like a lot of organizations did, call it either hazard pay or extra to cover, to be there, to work those extra shifts, to be sure that we had what we needed to care for the residents.
Carolyn, I just want to ask, I know I saw that question, thank you. And it also said, as it relates to our COVID infection control protocol. So, as we do, as we do see maybe some of our nursing staff or CNAs leave the organization and we have new people coming in and all, are we paying different attention or special attention to how we're onboarding them with kind of all of these new enhanced processes? And are those people coming, whether with less training or from different kind of settings that would, make it different in how we bring on board them?
Bharathi, I'll hand that one to you.
Oh, yeah. We do have an enormous onboarding process at Parker, and we do make sure that whoever who are hired into their position to cover them with a lot of education and training. In the initial stages, when we in COVID, we didn't have that expertise of designated IPs in the home, and thinking about with the infection control, stakes were high with all these changing policies and procedures. We did not want to take any breach in infection control. So we made it a point to make sure all of our nursing leadership positions we insisted on them to do an infection control training. We did take the resources which was available on CDC, and we insisted of making them go through the process of getting certification in infection control. Later part at the end of 2020, when they said that we need a designated infection preventionist for each home, it was easy for us to have a transition to put an infection control designee in each homes. That made us a little easier for us to do that, but because there is a lot of constant changes in the infection control space, so we need somebody to have a knowledge to trickle down to our frontline staff to make sure we are having that educated leaders to help them out.
And I also want to add, the methodology of teaching changed tremendously during this time. The days of having large meeting groups of staff who are all in one space, in one place, and going through lengthy presentations for education, which was the way we, have in the traditionally done some education and training, really transitioned and morphed into the short, the down, the one-on-ones, the small group, the huddles at the end of the day. People were isolated, people were behind closed doors, people had different, were wearing different PPE, they couldn't come out. So our ability to educate took on a very different methodology. It was really very constant, almost continual, one-on-one, small groups. Day in and day out, because the changes that were occurring during the peak, even just simply from a regulatory perspective, were very, very frequent. So it required us to be in the space, constantly in the space, making sure they understood what was happening today, what was expected today, what they needed to be wearing from a PPE perspective today, and what that all meant in terms of how to make sure they were operationalizing it correctly. So a lot of challenges on the education side, getting people to know and to learn and to follow and to practice good techniques. Very, very challenging thing to do, especially when you're stressed and there's a lot of work just in providing, direct care to residents. Mm-hmm. You're on mute, Judy.
Apologies. I was saying that might be a good transition, Carolyn and Bharathi, because as you're talking about all these new things and trying to educate people, if we go to the next slide and we can start talking a little bit about using technology to support infection control, now we're layering all this additional stuff on top of them. So I thought it might just be a good way to transition into this information.
Sure. So manual screening was our first starting place. The old paper and pencil, the old-fashioned way of doing things. It seems like a million years ago, like crayon and coloring book. It's kind of, we've progressed quite a bit since then. But early on, very, very early on, January, February, we were already doing paper and pencil screening with residents, with family members, with visitors coming through the door, asking some really hard questions. Wasn't always easy or received well, but we felt very strongly about protecting the environment and making sure that nobody kind of got through there that really had the potential to bring any illness into the home. That really transitioned into the new industry of temperature screening kiosks. You will see them maybe in hospitals and in other types of healthcare settings, where now you walk up to a kiosk and it recognizes your face and you swipe a badge and it identifies you as a person, takes a temperature automatically and asks some very relevant questions. Have you been exposed to this? Have you experiencing these symptoms? Have you had a cough or any difficulty? Yes, no, yes, no. The important part about the screening process, particularly when you have an electronic version in place, is that you can predetermine who will receive notification if anybody is a positive screen. So, for example, if someone, for example, has a temperature and trips a positive screen or answers yes to any question, even if it's accidentally, those emails get blasted out to the leadership of the home, to myself, to Bharathi, so we are always aware if someone has the potential. The person behind that front door or front desk, the nursing managers in the building, if it's nighttime, automatically are alerted so that they can respond to that individual, do an assessment of the situation and determine, was it a wrong swipe? Was it a wrong answer? Or are you really having some cough and congestion? Let's look at that. So important development, I think, in the world of screening, going from the manual paper to the kiosks. BioVigil, Bharathi? You are also on mute.
Bharathi, you're on mute.
Sorry. As we were talking about early on, when we were bombarded with a lot of education to our staff, we thought about the basic core elements. Hand hygiene was one of the things which we expected all the staff to do their competencies. We were doing biannually, now it became daily process. It took so much of manpower to stand there and do the education, go through the steps, making sure everyone was incompetent enough in a certain way they are doing their hand hygiene performance. BioVigil, when we introduced BioVigil, it gave us so much information. It invested in safety and extent for our staff and families. And it is a visual engagement for others to see whether we have performed our BioVigil. As you all see, I'm also wearing a badge on my chest. It shows we want to see green. If it shows red that anybody can visually see, will prompt them to go and do their hand hygiene and make it green. It gave us a built-in a routine, clinical routine for the staff, and it was an ongoing. It tracks the staff. It gives a roadmap where the staff entered which resident, which room, when they walk into the room, when they come out. It was a valuable information for us to see as a contact tracing, if to look at who went into this resident's room, who took care of them, how many times did they go and interacted with the resident. It gave us a real good information. The reports, we do get reports weekly basis. It is astonishing to see the amount, the number of times they do perform hand hygiene. It's not in just hundreds, it gives in thousands per week. And you can slice down the information hundreds of ways to see. It gives an opportunity to see who is doing hand hygiene always, who is not doing. We can trace down who is the naughty ones in the home, and it gives a lot of information to track down. Ongoing value of this BioVigil is hope it will help us in tracking down the flu influenza season 2. Anything else, Carolyn?
I'd like to just add to that clearly being able to monitor hand hygiene is really an extraordinary opportunity and resource for us to be able to have and deploy in throughout the organization. It's given us a tremendous amount of information, and if we look at the last since deployment, which was early going, I correct me if I'm wrong, Judy, but it was either February or March when we finally were, all out, full out, beginning the deployment. These badges are linked to the individual. So when a person comes in the morning, they link this badge to their own identity. So we know who's wearing that particular badge for the day. And to Bharathi's point, this has been an invaluable tool for us for contact tracing, because if an employee does end up having a positive test, we are able to know exactly where that person has been, what thresholds that person has crossed, what resident rooms they've been in, so that we can be very vigilant on monitoring and outbreak testing. I also think it's important. We've been able to correlate the reduction in overall infection and even beyond COVID in the last since deployment of this early on. And whether we saw it to be an anecdotal reduction, for example, in urinary tract infections and in pneumonias and in some of the other types of infections that we are used to treating in a more general sense, clearly there has been positive impact on the increase in hand hygiene and the reduction of infection. So we've always known what that correlation is. Now to be able to see it and prove it and be able to put some visual to that has been very impressive for the staff. The downside of the BioVigil technology has been, staff discomfort in the sense of early on before they really understood the purpose and the value and what it really meant. Ultimately, they really learned to appreciate it because it gave them reminders, right? You're due for hand hygiene, you're over the time limit, you've been in the room, your badge is turning colors. But because there is a tracking capability on these badges, the discomfort of the staff in the sense of, are you following me? Are you monitoring me? Are you watching my every move? And early on was a very real and valid question and concern. So we needed to really invest time in helping them understand that it really had nothing to do with that, but that at the end of the day, if we needed to know where they had been for the sake of resident safety or infection exposure, that contact tracing piece of this was really, really invaluable.
Carolyn, Bharathi, can you talk really quickly to so the badges are primarily worn by our clinical teams, but we did have some of our dietary staff when restrictions were in place, they were going in and out of the rooms. But you shared with me the other day one of the user groups that we're always surprised about with compliance, right? Some of the clinicians, because they're not in our daily process quite the same way, but we can also see what they are or are not doing.
Yeah, that's very true, Judy. It's always intriguing when we pull a report and I see, the physicians or the consultants in and out of the homes who are the naughty kids, as we put it, who need those general reminders about making sure that they are compliant with hand hygiene. Physicians can be notoriously forgetful in that respect in terms of, in and out of rooms at a very quick pace. So this is a great way of us to be able to kind of re-engage them as well and give them some reminders about best practices. Telehealth came of age during COVID. The ability to not only access residents in multiple different venues, for example, iPads, iPhones. I mean, it was all put into work during the peak of the crisis. We have several actual physical telehealth units. One is connected to a physician on-call service, so it is available 24/7 in our post-acute. We were also able to secure a second telehealth unit, the dictum unit, again, virtual visiting. It has the capability of electrocardiogram, of the physician being able to listen to lungs through the stethoscope that's attached to the system. Really important that Medicare and other insurance companies supported the reimbursement for telehealth visits, because obviously during the peak times when buildings were closed and we were concerned about nurses running around with tablets and iPads and machines and Kirabis and dictums was really, really important in getting those eyes on the residents in a very fast, quick, and efficient way. Bharathi, you want to tackle ATP?
To add on to our ATP is usually used in the hospital environment, but we wanted to see the efficacy of our cleaning process. We introduced ATP. It gave us an opportunity to assess for us to see whether the rooms after terminally clean, to make sure it is an opportunity to check whether they are clean enough. And it was one more thing to add on to our administrative staff to give a comfort level to make sure there is sanitation is in place. It's supported in infection control process because we do the reports for this. It is also when the rooms are assigned to the how environmental services, we can go and check on that, who is failing in these, and we can re-educate them and make sure that they really understand the cleaning process. But it is a lot to learn in this port of ATP cleaning verification.
I wanted to, there's a question, and I also wanted to interject on telehealth. Carolyn and Bharathi, when we were talking earlier, Carolyn, it reminded me, so during the emergency, telehealth was obviously used a lot when the physicians didn't have the same exact access, but our physicians were on site quite often. But it was used pretty extensively during the emergency and for those complex cases, but we see now that it's not used quite as frequently. And so that's something that we look at ways that we can maximize the use in the right situations. But I think that's just a learning around technology, right? When there's an immediate need, you use it, and then it's thinking about how you sustain that and how you continue to add value with that technology. But Carolyn, someone had sent in a question. This is a good time, I guess, to address it. The question is, there are communities that claim to have been 100% COVID-free, throughout this entire period, 2020 to year to date. How does Parker compare? How many COVID deaths, staff diagnosed with COVID, residents diagnosed with COVID? I don't know that you have those numbers on the top of your head, but if you just want to talk about that a little bit.
I don't have those numbers on the top of my head, but I would like to back up to the slide before, because I think it's relevant in terms of being able to address this very question. The environmental physical plan, a huge piece of a COVID experience. And what do I mean by that? When Judy shows you initially our various locations and the different types of structures that we have, the more traditional setting, the post-acute, which was also a much more traditional long-term care kind of skilled nursing setup, versus our Monroe home, which is the small home model, private rooms, big, large spaces, much more difficult to isolate in an environment like that. But what we did see was that the experience of COVID really was impacted by the physical plan. Our ability to be able to shut down units, lock down units, close down, isolate sections of the building, really were very dependent on which home we were really talking about. Very difficult to isolate a home if you have 16 rooms that are private and a living room, and it's vast, and there's a lot of space, and there's a dining room, and all of those things are occurring simultaneously. Very difficult to kind of close that off and isolate. We had, Parker had, I would say, I don't really comparative to others, hard to really say. We had resident deaths. We had no employee deaths. We had, I believe, maybe 1 or 2 employees hospitalized, and they recovered nicely. We hit the peak in the early going on, the April, I would say, April, May, the worst part for most of us in the industry. And then things, gradually started to settle down over the summer. And of course, once vaccinations became, the standard in January of this year, we've seen relatively nothing in terms of experience among our residents and staff. An occasional staff member may test positive, be asymptomatic. We all know that that's occurring out there, in terms of the general population. So we operate in accordance with the regulatory requirements. We do what we have to do. We, isolate the homes. But the ability for us, and as Judy may have mentioned, we are finalizing, or when COVID hit, we were in the phases of the final design for our post-acute building. And so what the experience of COVID did for us was to be able to get back to the table with the architects and say, okay, how do we build in negative pressure zones? How do we build in the ability to lock down certain areas, or to put negative pressure in some of these spaces, so that we can anticipate the likelihood that some other respiratory situation may occur in the future. And so we are now prepared for it. The other thing, that as an organization, having multiple different options also gave us the opportunity to be able to know whether or not a resident could remain in assisted living and isolate properly, or really whether or not their needs were best met in a post-acute setting where this, that we had a designated unit for COVID residents, for COVID admissions that came from the hospital. And so we could care for that person in the environment that was most conducive to their safety and recovery.
Carolyn, do you guys want to move on? Or I don't see any other questions outstanding right now. Do you want to move on to the data piece, or do you want to say anything else to this slide? Excuse me.
I just want to echo a little bit on the ATP piece that Bharathi mentioned. This technology has been used in hospitals for many, many years. It is the ability for technology to detect the presence of any bio waste or biology left behind on a surface, which has been a very important kind of additional overlay of infection control prevention in our space and protection in our space. For example, if a resident is discharged and a team comes in and does a terminal clean, we can send an ATP team, in there with our environmental services team to go in and test some of those high touch surfaces to be sure that when the next person coming along gets admitted to that space, we have a really high confidence that that room has been disinfected well, properly, and that there really is no potential for any cross-contamination to occur. So again, another good tool in the toolbox, not something we deploy on a day in and day out basis, but we use it strategically just to ensure we're operating under best practices. So data to drive utilization, decision making, and education. I think this slide really speaks to the transition that we had to make in really as an organization quickly from individual homes keeping data and information updated to a centralized system of tracking and trending, looking at things from a much more global perspective. Each of these technologies gives us a tremendous amount of information. And so initially it was up to Bharathi, for example, and the teams to really sort through the data suites and the reporting portals for each of these things and decide what information is relevant to us. What do we really want to know? Do we really want to know individually which employee may or may not be in compliance with the 94% hand hygiene benchmark that we set? Or do we really want to know what cross-contamination is occurring between beds in our semi-private rooms? What are we looking at and why are we looking at it? And then further, what are we doing with the information? Once we figure out exactly what it is we want to know, then how do we move that forward? And the fine line between making sure that we approach our teams from an educational perspective as opposed to, hey, by the way, you're not in compliance with your hand hygiene, as opposed to, here's what cross-contamination means, and here's why it matters, and here's how we need to help you understand why it's important that we track what happens when a caregiver takes care of the resident in A bed, goes to the B bed, and does not perform hand hygiene in between. What does that mean? What is the impact of that to each of the residents? Bharathi, you want to add something to that?
Yeah, it gives a picture about who enters the room, who does not enter the room. When they enter the room, did they do their hand hygiene competency? It gives them an opportunity to record their hand hygiene opportunities in that day. When do they did it? Is it just at the entry level of the residence room or when they exit the room? Between the beds, you said between A bed or B bed if they are sharing a bed. So it gives us an overall picture about the cross-contamination, their total hand hygiene opportunities, what they did for that week. We can slice the information in 100 different ways to see if there is any infection control breach has occurred.
One thing we do know is the word compliance since the start of this has really become almost central to everything we think, do, operationalize, create, to the point of, lost sleep, as I'm sure we've all experienced this year. Each regulatory body has their own version of compliance, which has also made this whole process, this journey, very challenging at times. CDC And CMS, not always lockstep. One may be ahead of the other in terms of what they're thinking or what they want to know. DOH also has their own perspective on how the state operates versus the federal level of regulatory bodies operate. So the need to make sure that we understood what the data was telling us, that we could really identify compliance or lack thereof of compliance very quickly, be able to see trends, for example, if there was an increase in infections, and we're not even talking about COVID, just in general, to be able to go to these data sources and say, are those team members, do they have what they need? Are they following guidelines? Are they in compliance with the benchmarks we've set? Do we need to go back and re-educate? Do we need to have a different conversation? Is the technology working, right, in the way that we need it to work? So from the compliance perspective, the data, the information, the data sets has been really, really critical to keeping us just focused on making sure that we were meeting all of the, we were in lockstep with each different regulatory body who sometimes it felt like had their own point of view on what they required.
Carolyn, can I comment on this? And I'm going to talk to BioVigil in particular, just as one of our newer technologies. I think it was the first time that Parker deployed this kind of technology across all the homes. So everybody's using the same exact thing, right? So now we're getting these reports, and at the beginning we did weekly updates with the teams. And if now the teams are now comparing against one another, and I don't want to say versus one another, but now they're seeing, okay, well, I've got an 85% compliance. They've got a 90. What are they doing differently? So I think there's a lot of best practices being shared across the organization, and that data really helped them. They started asking questions and collaborating with their peers. And I think in one example, it was really great. There was one home that maybe was having some challenges, and we took an ambassador team from another home that was doing really well. We brought over, I believe, a CNA, I believe a dietitian, and someone from environmental services, and they went over and then helped re-educate and walk alongside their peers. So I think it's great about data, but what the data tells us and then allows us to do an action is really important. And I just wanted to share that story because I think it tells you what you can do with the data in a very simple and effective way.
Yeah, Judy, that was very impactful. The ability for, for teams to kind of, share the knowledge, number one, to really be able to kind of be part of the solution for another home, for CNAs to really be empowered, because these are the guys that are wearing this technology who really are on the front line, making sure that they understood that, the purpose and the intent behind it was not in any way, nefarious or intended for them to be uncomfortable, but there really is purpose behind it. And I think over time, it has become like everything else, just part of the day-to-day fabric of operation. They know they have to screen, they know they have to put a badge on, and so for the most part, I think we've had tremendous success with BioVigil, but it was like anything else in an organization. When you roll out a whole new system or process, it was very time consuming, required everybody to be, to be leaned into it, to understand, the whys and the wherefores of what it was there for and what it was there to do. And to Judy's point, weekly calls and daily calls and tracking and looking at data on an ongoing basis was very, very important for the success.
Did you want to talk, or Carolyn? I'm not sure, or I can just a little bit about what we're doing with the Power BI, kind of how we're just, I said we went from manual, now we're getting data from all kinds of sources, and some of our vendors can, I'm going to use the wrong word, but we can integrate with their back end, and but some we can't, so we're figuring all that out. And now our next step is this Power BI pilot, if you want to talk a little bit about that.
Sure. So, data is only as good as what you decide to do with it, right? Or how you operationalize it, or what you understand it to be telling you. So, one of the things that we've undertaken this year as an organization is looking at data in terms of how do we centralize this information? How do we automate some of this information coming into a data portal, so that it does not overwhelm the clinical people or the clinical teams with manual input from information that can be redundant because we have multiple systems, and kind of give them the best opportunity to have an opportunity to have a comparative view, to have information not only about their home, but what other homes are doing. Power BI is the pilot, a data analytics platform that the organization has chosen. It is one that has inputs, as Judy mentioned, from various sources. It's an input from PCC, from Point Click Care. We have inputs from our electronic incident reporting system. Those are automatic inputs from pharmacy, from lab, so that data, as it's collected, whether it's relating to infections or falls or other risks in the organization or events occurring in the organization, is now all automatically porting into one centralized area. And the graph, some of the graph work that you see here on this slide is a representation of some of that information. So what's great about that is any particular home at any particular time opens up their data portal, can take a look, where are we by comparison to others? Where are we in comparison to ourselves last month, the month before? How do we take this information, build it into a quality assurance performance improvement project, into a QAPI, and work to improve the outcomes that we're seeing? The visual is critically important to the homes, and the fact that they're not bogged down with entering, how many falls did we have and who was it, and how many UTIs did we have and who was it, and that this data is automatically coming to a central location has been really, really helpful and very important in terms of quality assurance initiatives.
Thanks, Carolyn. I do want to add one thing to that, and then Bharathi, we've got a question for you. I think one of the things we're thinking about too is great. We're getting all this great data, but now we're thinking about what education do we need to help people to understand the data and then use it in some impactful way, right? So you say, okay, we're going to teach them about data. It's a whole different skill set. And some of our clinical team may have it, some may not. But so that's kind of one of our next steps is, how do you teach someone to understand data? It's a really interesting question, and I think that's going to be one of our next steps in this, right? Because this isn't about Carolyn and Bharathi taking this data and moving it out to the organization. This is those DONs, those ADONs at the home level, and using it for themselves. So I think that's something that our IT team and our CIO is considering now. So Bharathi, we had a question, I believe this was related to BioVigil. Have you had any frequent outliers, and what actions did you take for non-compliance? And you were on mute.
Oh, sorry. Yeah, we did have that. We do get, as I was talking to you about, we can slice and dice these information in many different ways. We do get a variant report on BioVigil. When we look at BioVigil variant report, it shows a high exception rate. Like when I say that somebody can go and pause this badge and go numerous times into the rooms. If that's the case, we do ask our IPs to go check on that individual who is really going on a high exception rate. And we do a one-on-one education, and we sit with them and ask them why they were on high exceptions rate. At the same time, we do a low activity rate of the badges. When we look at low activity rate of the badges, that shows a person who is not using the badge. It says that, okay, if the person is a full-time nursing employee, that means I expect that nursing staff to wear that badge all the time when she is in the building. So we do look at that a report when her schedule is, why they are going into a low exception rate. It does give us a lot of information regarding that, and it gives us an opportunity to re-educate them and reinforce the importance of the BioVigil.
What's really shocking, and Judy, maybe you can just, I don't know the numbers off the top of my head, but I remember when we first implemented this technology, the number of hand hygiene opportunities in any location was shocking to even myself. A long-term nurse who's been around a very long time. We're talking tens and tens and tens of thousands of opportunities in any given location on any given day, week, month, whatever the case may be. So it was a shocking amount of opportunities, meaning every time someone crossed that beacon, it would register as here's an opportunity, here's an opportunity. I think the short answer to the question too about the non-compliance is at the end of the day, compliance is not optional. So, you know, as much as we educate, as much as we try, we'll look at the badge, we'll look at the process, try to understand, is there a reason? Is our supply chain intact, right? Do you have the ability to get to that hand sanitizer quickly, easily? Have we done what we need to do to make sure you as our team member has what they need to make sure? But at the end of the day, it is about compliance.
I would only add, just because this was a project that I was pretty closely involved with, and the reasons for non-compliance were really interesting, right? And we had one particular maintenance person who was an outstanding employee and in all other aspects. And it was really just understanding the purpose of the badge. And when Bharathi was talking about exceptions, there are certain cases of an environmental service person is going to be in and out of a room to clean or something that you put an exception on, and then the badge isn't going to continue to alert. But understanding how to use the badge, there's some, for certain team members, there's some different, you know, things you need to know about. So I would say the majority of it really, right, was education and training. But I will say that this is a decision that was made early on. We just started this last year in, I think, January, and as Carolyn said, we launched in March across all the homes. And it was decided early on that we were not going to be pejorative or negatively use this as in a negative fashion in the launch and initial deployment of this, right? It wasn't going to be a performance objective that you were going to fail on within this first launch. I think as we get deeper into it, you know, we're coming up on our year one, we'll be doing a review. Those are conversations outside of my scope, but we purposely went in very much with an engagement mentality. How do we get people to understand, want to use it? And anecdotally, the really cool things that we heard is the nursing staff, I think, felt safe, might not be the safer, maybe, is that the right word, Carolyn and Bharathi, but also going home to their own family. You know, they have this process at work that is trying to keep them safer, and that makes them feel even safer going back into their community, their home. So I think the thought that Parker, you know, was doing this for their employees as much as their residents really started to resonate. So, you know, now we're on to phase two, right? Now we're trying to sustain and operationalize, and I'm sure we're going to learn a lot over the next 6 months with that as well.
The visualization of this badge really, from the resident family perspective, very, very important as well. You know, part of, they understood, you know, what the purpose of the deployment was, why this technology exists, why our staff members are walking around wearing these, you know, these badges with little green hands on them. And so gave them some assurances that we were following best practices, that we were monitoring and aware of the critical importance of something really, as we describe as being as simple as hand hygiene, but really not at all. You know, the cornerstone of any infection control process or program is hand hygiene. So our commitment to that as a core competence, from not only from the staff perspective, but from the resident side, the family side, I think has been an extremely positive experience.
So I'm sorry, Bharathi, excuse me.
No, I was just adding on to that, is it's so become the habit for staff to do we do pledging. Like when we use our hand sanitizer, we pledge towards the badge to give an opportunity to record our hand hygiene opportunity. So even when they are at home, when they wash their hand, they start pledging without their knowledge.
I would say before we might as well go on to the next slide, because I think we're on, it's about 3:10. But I do want to say, if anybody has a particular interest, just because of BioVigil, I think we were one of the first health long-term care organizations in the state to use it. It's a hospital-based product. But if anybody has questions about that, we welcome, you know, send us questions, or if you even wanted to, when I always check in with our clinical officer, right, the availability for visitors. But if you want to come and check out one of the homes and kind of see how it works in action, please reach out to one of us and we'd be happy to share what we've learned. So I think now we're going to go to early learnings, Carolyn and Bharathi.
So, you know, I think the relevance of this is really just to remind ourselves and each other that at the end of the day, it really is about people, right? It's, you know, all the infection control processes and policies in the world really only matter because people are either executing them or or on the other end of someone who is following an infection control process and we're trying to keep them safe. I think one of the things that we did learn early on, or at least midway through the crisis point, was how much impact the amount of changing and shifting we had to do with policy updating really had an impact on our team members. You know, after a while, I can imagine, and although, you know, they probably wouldn't say it to me directly, although many did, like, you know, a new version 3, version 5, where are we on this, right? Don't you know what we're doing? So our ability in the peak of crisis, really, as things were moving, as fast as things were moving, and I'm sure many of us experienced the same thing, helping the team to understand it really wasn't about us not being sure. It was about we were getting information as fast as we were getting it and had to turn it around to them as quickly as humanly possible, and then educate and execute. So very, very difficult for people working under duress, under stressful situations, who had families, obviously who had worried families at home. They were working long, hard hours under really difficult circumstances. So at the end of the day, always remembering that, engaging staff, remembering that I can sit in my office and write all the policy in the world, but at the end of the day, it's going to go to someone whose hands are going to touch it, are going to execute it with others, are going to put their hands on our residents and elders and participants, and making sure that when we're always mindful of that, that we meet them where they are in terms of education and training. When you're under stress, sitting in a classroom, not really the most effective form of education and training. Making sure you can go down the hall and engage someone one-to-one under those circumstances, far, far better way to reach the people we needed to reach and give them the information they needed. Bharathi, thoughts? Anything you want to add to that?
I do agree with that. The constant evolution of the information, what we got, we need to consider the stress of our staff on the other end, because they are the one who are really executing the changes, what we are bringing into. A constant shout out. On Monday we come, we say, okay, you're going right. And Tuesday we are saying you're right, marching to the left. It's not easy for them to, we do put them in confusion state, but we have to be there at that level to educate them constantly, make sure they're comfortable about the changes in information, what we give.
I want to ask, because Bharathi and Carolyn, you just talked about something we were talking about the other day, the words adjust, adapt, redirect. You know, and you see some of those notes on the other side. What's most important? Teach me, focus, prioritize. So you talked a little bit about distrust, right? And whether it was really directed at the Parker leaders, or it was just an overall distrust of information, right? Because so many things. And we talk about building back that trust. Not that we've lost it, but how do you know we're not out of COVID, right? But what do you think about in terms of, you know, building that trust, that continued engagement? What do you think about that, you know, and how are we moving that forward?
It's a very challenging question. We did talk about this the other day. I think, you know, when you're on the front line and you have anxiety about being there, right? You're working in a COVID unit, and to Bharathi's point, we gave you information yesterday and we got information that was different today, and therefore how to give you that information today that was different than yesterday. So, you know, it's hard. There's no time to stand by and say, listen, what, you know, it's what we've got. It's what we've been told. It's what, you know, it's the directive that we've been given today, which is different than yesterday. Hard to really kind of communicate that specific. I think what is important at this juncture is we recognize that people are tired, they're weary. Yes, we're sitting in a little bit of a lull time, or at least it feels that way. No one knows what's coming. And of course, you know, as the winter now starts to approach, where that all fits in terms of our experience with this COVID. But I think it's important that organizations are mindful that the effort needs to be put into staff engagement, that we actually have to, as an organization, really as recognize our stakeholders need something now from us that we're not maybe able to give within the last 8 to 9 months. And so that I don't have the magic answer as to what that engagement looks like, but what I do know is that we as an organization do know and are working on how do we approach our teams now? What can we do to be sure that we've built the bridges back towards each other, that we have some real understanding about what this has been all about, and how we've, and to really listen. I think part of the conversation has to be, us learning about where did we go wrong? What could we have done better for them? How could we have communicated the information in ways that would have been more simpler, more concise, more succinct, so that it was not overwhelming to constantly get more updated information. So, I think it's important that the dialogue has to start, and it needs to start, I think, at a time when things are not in crisis, which is kind of where we're situated at the moment. So I know it's work that our organization is doing and is very focused on, and will be doing in the upcoming months as we go forward.
Bharathi, you want to add anything?
For me, that's true. Like, we have to start educating. I think our staff has understood what we went through during the last 1 year period. Today, when we do walk in a surgical mask in the morning, and in the afternoon, if we change it to N95, they do understand now. They do know, hey, there is certain thing. They are in outbreak. This is what is needed. So it takes time for them, but probably when it's not an emergency, or we should take time to rationale and give the reasons and educate them properly.
And they need to be recognized. I mean, they just, the work has been, obviously for all of us, very, very difficult, but for our care partners and our frontline and our clinical teams and those that are really out there every day touching the patients and putting their arms around the patients and the residents and the participants. And so, recognition, I think, is really, really important. Understanding where they are in terms of feeling, what's been happening in their lives, in their world, and just being an organization that that is really committed to supporting the teams. And doing everything we can to make sure they know and they feel that, that care and support.
So I think that's the end of our official presentation, and I don't see any new questions in the box. Kathy, I don't know if you just want to see if anybody else has any questions, or if there's something that maybe we went over a little quickly, or somebody wants clarification. I leave it with you at this point.
Hi, sure. I did see some more things in the Q&A. Did we get them all?
I think so. Yeah, I just cleared a few that we had answered.
Thank you. That was an excellent presentation. I thank you. And I just, one of the things I heard you saying over and over is educating and learning, which you did with your staff. And it sounds like it's a two-way street. I think those are things that we can apply to everything with COVID. So one of the questions that I had for you was, if you had a team, you have a staff, and you have experts. If you don't have that team and you want to prepare for whatever is next, whether it's the flu season, whether it's COVID, whatever variant we get to, how can people find help planning? If they're a small organization, if they don't have that staff, what should they do and how can they find help?
I think the easiest answer for me is to reach out to other organizations, right? What are you doing? There are, and Bharathi, I know can give even more, a little bit more commentary on this. There are a lot of organizations that hold weekly conferences. Rutgers, for example, has Project Echo. CMS will send out blast invites, DOH blast invites, New Jersey Hospital Association, all kinds of sessions for education, for training, for information. There's a tremendous amount of information out there. It's just connecting with some of the organizations to say, listen, can you get me on the listserv to know when things are coming, so that we can participate, we can avail ourselves to some of this information. Bharathi, I know you sit in on conferences of probably at least 2 to 3 a week, so you might want to comment on that as well.
Yeah, I think having a designated person to get the latest information, CDC is a great source to get it. It gives the guidelines to any of the infection. You can go and search on it. They have COCO calls. You can attend COCO calls. I did do all our IPs to attend ECHO session for the infection control. They have a lot of certification programs on CDC. It's a free education. You can go on yourself, enroll yourself, and get the information.
Very, very helpful. I see one more question popping up here. Just a thank you. Well, I want to thank you for joining us today. And this, you covered so much, and this has been really, really helpful. If we could just rewind the clock to, 2 years ago and then prepare, what a difference it would have made. For all of you who joined us today, we are going to post this recording on our website under our, I think it's under events webinar page, and we'll also email it out to you. And I think this is the last Parker webinar we have for 2021, but we are already starting to make plans for 2022 with new topics, more speakers, and I look forward to seeing you then. Thank you again for your presentation, and thank you everybody for joining us today.
Thank you. Bye.